going to spend the next part of this presentation on predictive biomarkers, and a lot of the work we did was on developing a prognostic test for early-stage lung cancer, but of course there's great predictive biomarkers as well, and I'm just going to give you a brief overview of what's available and how it's being currently applied in the clinic. If you look at the different mutations that are commonly associated with lung cancer, the most common ones are shown here, and of those common mutations, the four most relevant to being now looked at and evaluated as having predictive biomarker power are EGFR, KRAS, which are the two most common mutations, and then also BRAF and ALK. We talk about EGFR, which is one of the most researched and well-studied mechanisms that drives the formation of cancer. We know that EGFR is a molecule that basically, when it gets turned on, it leads to all these things that are associated with cancer: proliferation, survival, adhesion, invasion, metastases. The property of this specific receptor, which is a growth factor receptor, that when it's turned on all the time, as it often is in cancer, it leads to all these downstream effects that cause cancer. When we see this happen in lung cancer, and we know that it happens in a certain percentage of lung tumors, we saw it in about 25%, it just so happens that we have therapies to stop this process. And these are called tyrosine kinase inhibitors. Erlotinib, or Tarceva, and gefitinib, or Iressa, are two of the readily available tyrosine kinase inhibitors that specifically target the EGFR molecule, and they're able to turn off this process and basically turn off the downstream effects that propagate the development and propagation of lung cancer. Because of this, we know that if you test a certain patient and that patient is positive for having an EGFR mutation, we know that there are now therapies available to help turn off that process. Just so happens that there's actually pretty good evidence now that some of these targeted therapies may in fact improve patients and help with patient prognosis. This is the basis of how we can now start to think about integrating predictive biomarkers into our evaluation and treatment of non-small cell lung cancer. Some of these recommendations are actually now in the current guidelines published by the NCCN. For example, they recommend consideration of EGFR tyrosine kinase inhibitors if somebody has an EGFR mutation. For example, this schematic is one that's been proposed recently of how the current tests that are available, the predictive biomarkers that are available for lung cancer, should be integrated in a clinical setting. You can take a patient who's been diagnosed with lung adenocarcinoma, for example, and test them for KRAS, which is the other major mutation that you saw that was present in about 25% of lung cancers. And we know that if that patient tests positive for KRAS mutation, one of the agents you should not use is these tyrosine kinase inhibitors, because they're actually very ineffective in patients with a KRAS mutation. If that patient does not have a KRAS mutation, however, you can then conceivably go on to test them for an EGFR mutation. If they have an EGFR mutation, you should consider giving them a tyrosine kinase inhibitor. If they don't, there's other molecules and predictive biomarkers that you can then test for and try to tailor your therapy based on the results of these tests. Worth mentioning are two other molecular predictive biomarkers. One is ERCC1. You may start to hear about this more and more often. It predicts resistance to platinum-based therapy. And RRM1, which predicts resistance to gemcitabine. So this is just a brief overview of what's really out there and now starting to get integrated into the clinic in terms of evaluation and incorporation of predictive biomarkers. One last study that I wanted to mention is the BATTLE study. And this is really a nice study and I think a paradigm of how studies are going to be designed going forward in terms of adjuvant therapy, and also how things are going to look to you if you're a patient with lung cancer in the clinic. When you go into your doctor's office, this is what they're going to tell you basically. This is how treatments are going to be personalized in the future. So this was a study that was recently published that looked at over 200 patients. This was a nicely controlled study, which they looked at these patients and they assessed for the presence of 11 potential biomarkers. And based on the results of their predictive biomarker testing, they were then assigned to one of 4 chemotherapy regimens that they thought would help these patients based on their biomolecular profile. In other words, the therapy that they received was personalized for the mutations that were detected and the genomic information that was detected in their lung tumors from core biopsies. And they found that in this study, there was a number of biomarkers that were associated with positive response to specific types of chemotherapy, and they're listed on the right side of the screen. If you had an EGFR mutation, for example, you were surprisingly responsive to a tyrosine kinase inhibitor. These other predictive biomarkers that are listed here also showed that you're likely to respond to a certain therapy. Again, I think that it's a really great study. It's a glimpse of the future and how all studies probably are going to be designed with the incorporation and acknowledgement that there are molecular biomarkers out there that can help personalize and tailor chemotherapy regimens and adjuvant therapy regimens after the diagnosis of lung cancer. You're going to walk into your doctor's office and they're going to tell you, look, we sent your tumor off for analysis. Based on the results of this analysis, which included these various biomarkers, we think you're going to respond best to this particular chemotherapy regimen. And you'll talk about it in those specific terms. And it'll be very personalized to your specific tumor. So I really like this study, and I think it's, again, a paradigm of what's going to happen going forward. We've talked a little bit about predictive biomarkers, and now let's switch back to what our research is focused on, which is prognostic biomarkers. So again, when a patient gets diagnosed with a disease, is there something out there to help us tell more accurately what their outcomes are likely to be? Again, for various reasons, probably historical and ease of getting genetic information through gene expression and microarrays and so forth, a lot of these prognostic genomic biomarkers have developed by using different technologies available to measure gene expression in terms of mRNA. And the two most popular ways to do this are microarrays and quantitative PCR. Microarrays were developed in 1995. They offer a genome-wide snapshot of RNA expression. Otherwise, you can look at somebody's RNA expression and what their genes are doing at a certain instant in time all at once. And nowadays, we have gene arrays that will assess the entire human genome. In 2001, this technology was applied to lung tumors, and for the first time, it allowed the identification of which tumors may be primary versus metastatic, to identify potential novel subclasses of tumors. But importantly, it quickly also allowed for the prognostic profiling of early-stage tumors. Most of these studies were designed in the following fashion. We took a certain number of tumors that were snapped frozen tumor samples. Microarrays have to use basically tissues that are designated for research, that as soon as the surgeon removes it from the patient's body, it's put into nitroglycerin and snap frozen in the operating room and then brought to a research setting. And then microarray technology is used to basically profile and assess gene expression of all these different tumor samples that are brought to the lab. These tumors are then given a certain risk profile that's basically associated with good and poor outcome. And then this risk profile is applied to a validation cohort, and we can see through this validation cohort, which is a separate cohort, how well these prognostic gene signatures perform in a different patient population. The first group to publish with these findings was the group Batterjee et al. In 2001, and they looked at certain gene microarrays on over 180 frozen tumors, and they basically came up not only with novel subclasses of adenocarcinomas, but they also discovered that certain subclasses of adenocarcinomas in the early stage disease had better and worse survival depending on their particular genetic profiling. And since this study was published in 2001, there have been a number of studies that have taken off in the past decade or so, which have looked at the same question. So what was identified was, can genomic information be used in a helpful way to improve the accuracy of how these patients will do or to improve patient prognosis after the diagnosis of lung cancer. If you look at the 15 major studies or so that have been published in the past decade since that initial report, you'll see some common patterns. One is that most of these studies, again, use microarray, which is a great way to get a lot of information all at once, but it does have limitation, as you'll see in the next column, of using frozen tissues. Quantitative PCR has also been used by certain groups. Just so happens that all those groups also chose to use research-grade frozen tissues, which is not really relevant in the practical setting. We'll get to that more in a minute. By and large, these studies that were published had somewhat smaller patient populations, on the order of either under 100 or just a few hundred patients. There was only one study that was set up in a particularly rigorous way in which the prognostic gene signature was first developed and then tested blindly, which is called a blinded validation, on a separate cohort of patients. And so, in other words, you have this signature that you develop, and without knowing how it performs in any other group, you then send it out for separate tests. And it's trial by fire that may fail. And the only group to actually set up their test that way, unfortunately, did fail in stage 1 disease. Their gene classifier was not able to reliably separate stage 1 patients at high and low risk of mortality from lung cancer. Looking at these studies, when our group became interested in answering this question, we really thought that what needed to be done was not only to develop a very practical assay to bypass this particular problem of only using research grade snap-frozen tissues, because we knew that wasn't really relevant to the population at large. And second of all, we wanted to do it in the proper fashion, which is the same way the Shedden et al. Did it, which is develop a classifier and then test it with a blinded clinical validation in 2 separate cohorts of patients.
Thanks for listening. If you like and learn from our GraceCasts, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.